Hello everyone, this is Dr. Shambhavi. I am here to help you how to clear your DNB Pediatrics in first attempt. I have done it and you can too. It is not as tough as it is said. There are few things and few topics that you need to know, few areas that should be cleared, your way of presentation, your way of writing the exams, and a lot of small aspects which matter in the exam. I'm here to take you topic by topic. We will scrape through few areas of importance. Now we'll begin with one topic. This is entirely based on Nelson Textbook, and we will start the chapter Hydrocephalus. It's a very easy chapter. Just few facts and few things here and there that you need to remember, and then you're ready to write the answer. So first, to understand hydrocephalus, we need to know um, where is CSF formed and how is it circulated. So basically, the CSF formation, 75% of the CSF, it is produced by the choroid plexus. Rest 25% of the CSF, it is produced by extrachoroidal sources, which is going to include the capillary endothelium and the ependymal lining, that is the endothelial lining of the capillaries as well as the ependymal lining. So this was about the CSF formation. Next, the regulation of CSF production. So we have these sympathetic stimulations, we have these autonomic nervous system, that is the adrenergic stimulation, which is going to reduce the CSF production. So whenever there is an adrenergic stimulation, you will get a decreased CSF production, whereas the cholinergic stimulation is going to increase the CSF flow. It may as much as double the CSF flow. Which stimulation? The cholinergic stimulation. Okay. Now, what is the normal CSF production and volume? The production in children, the rate of production, the normal is hourly 20 ml of CSF is produced, that is 20 ml per hour. And what is the total CSF volume in infants and adults? In infants, the total CSF volume is 50 ml, whereas in adults it is 150 ml. Okay. Now we'll learn about the CSF. We have just read about the CSF formation and absorption. Okay, so these are a few things that you need to know. We have the lateral ventricles, we have the anterior horn, we have the posterior horn, we have the inferior horn, we have the third ventricle, then we have the foramen of Monro, okay, connecting both. Then we have an aqueduct of Sylvius, the fourth ventricle, and then we have foramen of Luschka and Magendis. Okay. The circulation of CSF, whatever I just told you, the lateral ventricles, through the foramen of Monro, you enter the third ventricle, through the aqueduct of Sylvius, the fourth ventricle, and then the exit pathways, that is the foramen of Luschka and Magendie. The CSF is going to enter the basal cisterns. This was exactly what I told you. Okay. Again, this is the arachnoid granulations. What you see, this is your site of CSF production. Okay, the choroid plexus, and you have, this is the lateral ventricle. Then you have the foramens which are connecting the lateral ventricle to the third ventricle. Then you have aqueduct of Sylvius, which is going to connect it to the fourth ventricle. Okay, and then finally it is going to exit through the foraminas of Luschka and Magendis. Same what I told you. This is the lateral ventricle. You have the third ventricle, and the cerebral aqueduct. Cerebral aqueduct is same as aqueduct of Sylvius. Okay, cerebral aqueduct, it is going to enter the fourth ventricle. Okay, and through the lateral and the median apertures. So the lateral is Luschka, L for lateral is Luschka, M for median is Magendie. It is going to enter the subarachnoid space. It is going to enter the subarachnoid space, that is the basal cisterns, and by the arachnoid villi of dural venous sinuses. So we have some venous sinuses, right? So dural venous sinuses, we have arachnoid villi. So this villi is going to help in the absorption of CSF, and it is going to get it is going to go into the venous blood. Okay, so this is the circulation. Okay, circulation and how CSF is formed and recirculated. Okay, now the CSF absorption, what I told you, 80% of the CSF absorption is going to occur by the arachnoid villi. The remaining absorption is going to occur through the lymphatics, the nerve root sleeves, and the choroid plexus. Okay, so majorly 80% is absorbed by the arachnoid villi. Okay, Next, we will learn about the definition of hydrocephalus. So this is what is called as a hydrocephalus. So if you see a baby with a giant head, okay, which is a giant fluid-filled head, okay, so hydrocephalus is enlargement of a ventricular system due to increased CSF production or decreased absorption with or without signs of raised ICP. So basically, if you see a baby with a giant fluid-filled head, you can naturally think of two things, major things. So maybe there is more of a fluid production, or maybe the body is producing adequate CSF, but the absorption mechanism is defective, and because of the defective absorption mechanism, whatever fluid is getting secreted is getting accumulated. So either because of increased CSF production or because of a decreased absorption of CSF. So remember, this is a very basic definition of hydrocephalus. So ultimately, this increased CSF production may cause increased intracranial pressure, but initially the child may not have a raised ICP. Okay, so with or without raised ICP. So this is what is the definition of hydrocephalus. Okay, so you can see this is what you will see in the radio imaging. Hyperlucent areas. Now, etiology is, you have to remember age-related causes. You have to remember congenital associations. Okay, so etiology wise, up to 2 years, that is a neonate to infancy, you have perinatal hemorrhage, meningitis, aqueductal stenosis. So either because of some hemorrhage, some blood-filled areas which are hampering the secretion or absorption, whatever it is, perinatal hemorrhage, so meningitis, okay, that is the infection part. Or you can have a stenosed aqueduct, okay, aqueductal of Sylvius may be stenosed, which is hampering the flow of CSF, okay, obstructing the flow of CSF. Next is early to late childhood, so at the age of 2 to 10 years, okay, you can have a posterior fossa tumors, okay, so we have a posterior fossa tumors which can hamper. So basically this entire system is located posteriorly, and any tumor which is arising in the posterior fossa, the posterior part, then it can hamper the flow of CSF, okay, leading to hydrocephalus. Now, what congenital associations you can think of? You have to remember two things, which is Chiari malformations and there is a Dandy-Walker malformation. So important is the Dandy-Walker malformation is because of atresia of foramen of Luschka and Magendie. Okay, so whenever there is an atretic Luschka and Magendie foramen, definitely, as I have explained you the anatomy, that will be a disruption in the disruption in the flow of CSF, right? Next. So when you think of Dandy-Walker syndrome, this is few points that I had just added. That is, the corpus callosum may be abnormal or absent. Okay, this is corpus callosal agenesis can be seen, or you can have a cyst posterior fossa, you can have a cyst, and you have enlarged fourth ventricle. The fourth ventricle can be enlarged. Why? This is just because there is a flow disruption, so you get a increased pressure and enlargement, and you can have abnormally formed cerebellum, and because of all of these raised pressure changes, you can have a brainstem compression. Okay, so these are the things in the Dandy-Walker syndrome: corpus callosal agenesis, cyst, enlarged fourth ventricle, abnormally formed cerebellum, and brainstem may be compressed. Now, what are the causes of congenital hydrocephalus? So remember these causes: aqueductal stenosis, that is the aqueductal diameter of less than 0.25. There could be neural tube defects like myelomeningoscale, Chiari-2 malformation, congenital foramen of Monro atresia, posterior fossa malformations like Dandy-Walker and Chiari-1. Then we have an intracranial cyst and vein of Gallen malformation. So basically a cystic condition, okay, or a vein-related condition, okay, or some congenital anomaly, okay, like atretic conditions, okay, atresias, okay, fluid-filled cyst, okay, and stenosis of the pathway. So, okay, so you have to just read it twice and twice and just try to remember everything. Causes of acquired hydrocephalus, you have this is all congenital, okay, since birth. Acquired is tumors, okay, can have a tumor obstructing the CSF pathway, intracranial cyst, Choroid plexus papilloma. So papilloma will cause increased secretion. We can have infections, we can have inflammations, intracranial hemorrhages like SAH. Then you can have IVH, intraventricular hemorrhage, and vascular malformations like aneurysms and AVMs, arteriovenous malformations. Okay, so remember tumors, papillomas, infections, inflammations, cyst, hemorrhage, and vascular conditions. Okay, try to summarize everything, whatever you are reading, just try to summarize in 1 to 2 points so it becomes very easy to recall, because these exams they happen back to back, and then you don't get time to revise everything. So all these summaries will help you form the answer, because you may not remember everything, okay, but you can remember what points, okay, you can remember these small headings, okay. Next is types of hydrocephalus. You have a communicating hydrocephalus, you have a non-communicating hydrocephalus. These are two types, okay, communicating and non-communicating. What is communicating? CSF can flow through the ventricles, but the absorption is defective. That is a communicating hydrocephalus. And non-communicating means CSF cannot flow because there is obstruction inside the ventricles. So non-communicating means the CSF cannot communicate with each other. And when can CSF not communicate? When there is an obstruction. That is a non-communicating type. Communicating means all the CSF can communicate with each other. Then what will be the problem? Naturally, it will be the absorption. Okay. Next. So communicating may just remember a few things, that you can have a hemorrhage, okay, absorption is defective, meningitis, normal pressure hydrocephalus, okay, normal pressure hydrocephalus, leptomeningeal tumor infiltration, choroid plexus papilloma. So these will always just think of everything, okay, papilloma, absorption is defective, leptomeningeal tumor infiltration, okay, meningitis, subarachnoid hemorrhages. Non-communicating hydrocephalus may have aqueductal obstruction, unknown carry malformation, Dandy Walker, benign intracranial cyst, vein of Gallum aneurysms, congenital malformations of third and fourth ventricular outlet. Okay, so these are the non-communicating hydrocephalus, causes of non-communicating hydrocephalus. Now, what are the clinical features? So think of a child who is having a fluid-filled brain. Okay, so the child will have a headache, okay, because you have a CTZ zones, okay, chemoreceptor trigger zones, you have all the vomiting centers in the brain. The child will also have vomiting with the nausea. There will be kind strokes breathing, okay, the respiration will also be effective through kind strokes breathing, okay. You have all the print nerves, so naturally there will also be involvement of the papilla edema, okay, the disc edema will be there. There could be neurogenic pulmonary edema, okay. These are all the acute hydrocephalus, the clinical features. Severe ICP will be lead to decorticate and decerebrate posturing. Now, what is decorticate and decerebrate posturing? Remember, decorticate. So you have decorticate, you have two C's. So there is a flexed posture. Arms will look like C. You can see this is C. Arms will look like C. That is, arm is going to move towards the cord. Okay. C's and cord. Remember C's and cord. Okay. Arms will move toward the cord. Cord is what? Spinal cord. Okay. Problems with the cervical spinal tract or a cerebral hemisphere. So this is going to happen when there is a issues with these. Decerebrate extensor kind of a posturing you will see, that is decerebrate posturing. You will see arms are like E. Arms are like E. This is all extended. Remember, this is all extended. There is no flex posture. You had multiple E's here. E, 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 E. So there are 4 E's, right? So whenever you think of this decerebrate posturing, think of problems with midbrain or the pontine area. Okay. Now, chronic hydrocephalus, you have a lot of things. And there will be, it's a chronicity. So you get a progressive enlargement of the head. Okay, the head is going to progressively enlarge. You get when there is progressive enlargement, you will get suprachiasmatic separation. Okay, and when you do a percussion on the skull, you get a crackpot sound. Okay, that is known as a Mc-Evans sign. So remember, that is known as a Mc-Evans sign. You get upward gaze kind of a movement, eye movement. That is known as Paranot syndrome. Okay, the scalp veins will be prominent. You see the prominent scalp veins. Okay, this is the prominent scalp veins. Okay, then all of these things is going to affect the development of the child. So developmental delay, the mental retardation, okay, the IQ is also affected, and you get a deep behavioral disturbances. So McEwen's sign, prominent scalp veins. Now, when you look for a radiological evaluation, you get a skull X-ray findings. So you get a sutural widening, you get sutural widening, posterior clinoid erosion, silver beaten appearance of the skull, and ballooning of the sella turcica. Sella turcica is the site of pituitary, right? So you get a ballooning of the sella turcica, silver beaten appearance of the skull, posterior clinoid erosion, and sutural binding. So this is a plain X-ray. You get a separated sutures, okay, sutural widening, okay, and silver beaten appearance of the skull. This is the indirect signs of increased ICP. CT scan findings is going to help determine the type of hydrocephalus. And obstructive, you will get a, in obstructive there is the CSF cannot communicate, so it's a non-communicating type, right? The CSF is not able to communicate. Why? Because there is an obstruction. So whenever there is an obstruction, you get a back pressure changes, and because of back pressure changes, you get dilated lateral and third ventricle. The lateral ventricles and the third ventricle will be dilated. Naturally, your CSF is obstructed. Okay, there will be back pressure changes because of the obstruction, and there will be dilatation of the remaining areas. Okay. Next, communicating hydrocephalus. May get dilatation of all the ventricles. Now you get signs of raised ICP. So signs of raised ICP is appreciated in CT as periventricular lucencies. So a lot of periventricular lucencies, and there will be loss of cortical sulci. So you see the sulcus, the sulci, okay, the depth of the sulcus, okay, this is lost, all because of the pressure changes, raised ICP, okay, loss of the cortical sulci, okay, bilaterally. Now what is Evans ratio? It is used to diagnose ventricular enlargement. So it is a ratio of bifrontal width of the lateral ventricles to maximum brain width. So this is the bifrontal width, and this is the maximum brain width, and you divide the width. That this ratio is known as Evans ratio. Normally it is less than equal to 30%, but in hydrocephalus you will see this is increasing. Okay, so this is increasing, the bifrontal width is increasing, so you get a more than 30%. That is known as Evans ratio. So Evans ratio of more than 30% is defines ventriculomegaly. So greater than or equal to 0.3, that is 30%. Okay. Now MRI evaluation. So mid-sagittal MRI, when you do, it is going to help identify the aqueductal stenosis, okay, and the length of obstruction. So how much the aqueduct of Sylvius is stenosed, okay, how much is the lumen diameter, and what is the length of obstruction, okay. So the diameter and as well as the length which is constructed. So that is, you can help with, you can identify with the mid-sagittal MRI. Better visualization of the periventricular white matter changes. Okay. Now cine MRI you can do. So it is going to demonstrate the CSF flow through the aqueduct. It is going to evaluate the CSF flow dynamics. It is going to help decide the need for VP shunt. So you may have to do a VP shunting. I'll tell you about that later. So basically this is a flow kind of an MRI. You can visualize a flow. It is going to demonstrate the CSF flow. Okay. Now what are the consequences of hydrocephalus? You have a lot of consequences. You have hypothalamic dysfunction. All hypothalamic dysfunction, it is responsible for the secretion of the hormones, pituitary hormones also. So the height may be affected, short stature. It can cause over secretion of growth hormone also, gigantism, obesity, so delayed puberty, primary amenorrhea, menstrual irregularities, and diabetes insipidus. So it is a bimodal kind of a effect. Okay, so short stature along with gigantism, obesity, delayed puberty, okay, menstrual abnormalities, okay. Neurological effects may there will be limb ataxia, spasticity, difficulty in the walking, truncal ataxia. So ataxia of the trunk as well as the limb, as well as spastic limbs, and because of all of these problems there will be difficulty in walking. Okay, try to learn things in a circular manner. Okay, try to link every point to each other. That helps you remember the points easily. Because Stretching of the periventricular pyramidal tract. So this is because of the pressure changes. All the problems, they are majorly because of the pressure changes. There is stretching of the periventricular pyramidal tract leading to all of these neurological effects. Other effects is neck pain due to cerebellar tonsillar herniation. Okay, so herniation, brainstem herniation, the cerebellar tonsillar herniation was one of the important, very risky effect. Okay, mm, this life threatening. Then you have another complications like ocular complications, papilledema, secondary optic atrophy. Medical management, temporary management is aimed at reducing the CSF production. Okay, how do you reduce the CSF production? With the help of drugs. So first you can use a carbonic anhydrase inhibitor like a acetazolamide. You start at 25 mg per kg per day. Maximum you can go up to 100 mg per kg per day. Okay, you have to look for electrolytes. You have to monitor ABG of the child. Okay, furosemide you give 0.5 to 1 mg per kg. Okay, this is per dose. Okay, and monitol you can give 0.25 to 0.5 grams per kg every 6 hourly. Okay, every 6 hourly. Steroids you can give 0.25 to 1 mg per kg per day in a post-infective hydrocephalus. Okay, that is also going to help in inflammation. The next is the surgical management. You can go for a lumbar drainage. It is used in communicating kind of a hydrocephalus. You can do a complication of lumbar drainage. It can cause post-tapping headache and tonsillar herniation. So this is how you do a lumbar draining. Okay, it will help drain the extra CSF fluid and reduce the pressure. Okay, next is a VP shunting. CSF is drained from the ventricle to peritoneal cavity. So you connect the brain ventricle to the peritoneum, and all the extra CSF is drained via a silicone tube. That is known as a VP shunt. That is ventriculoperitoneal shunt. Now there are a lot of complications. This is asked: complications of VP shunt infection, obstruction, migration, bleeding, ascites, subdural effusion. Remember, anything which is foreign body can get infected. The infection can cause attract cells. It can cause obstruction also. It can cause migrate and cause obstruction also. Okay, then it may bleed. Okay, there will be more fluid getting accumulated in the peritoneum, leading to ascites and subdural effusions. Okay, best result is going to occur with early insertion before the brain damage. So if you want a good neurological outcome, you have to do this procedure as early as possible. Okay, this is how is it done. This is the skull, this is the brain tissue, and these are the ventricles, and you connect the ventricle, okay, via a pump. Okay, this is the reservoir, and this is a ventricular catheter which is going to connect it to the lining, connect it to the peritoneum. Okay, ventricular atrial shunt, it is used when abdominal pathology is going to prevent the VP shunt. So ventricular atrial shunt, the complication is, so next what you can do is connect the ventricle to the atria of the heart, but this is a risky procedure. You can get complications like endocarditis and then the secondary glomerulonephritis. Okay, ventricular atrial shunts are used to drain CSF into extracranial spaces. It is they are provided to transfer the CSF fluid from the cerebral ventricle into the right atrium of the heart. I've already told you. Next is the ex vacuo hydrocephalus. Now what is this new concept? Ex vacuo. So this means ex vacuo hydrocephalus is here. It is ventricular enlargement. It is going to occur because atrophy of the periventricular brain tissue. Basically, the periventricular brain tissue is getting atrophied, and because of which you see that the ventricles have enlarged. That is known as ex vacuo hydrocephalus. Now, the CSF pressure is normal because the CSF dynamics is normal. So basically, the pathology lies periventricular. Okay, not in the ventricles. Remember that. That is hydrocephalus ex vacuo. Okay. One more thing that you can do apart from lumbar drain and ventriculoperitoneal ventriculoatrial shunting is endoscopic third ventriculostomy. So endoscopic third ventriculostomy. Okay, the concept lies in the name. Small opening is created in the floor of the third ventricle. The CSF, it is going to drain in the prepontine cistern, and it is going to bypass aqueductal obstruction. So this you will do in cases of aqueductal stenosis. Okay, you create a small opening in the third ventricle, and that will directly drain into the cisterns. So basically the CSF is drained in the cisterns. a lot of cisterns surrounding. Okay, so the CSF will directly go into the prepontine cistern bypassing the aqueductal obstruction. Um, Thank you. I hope this lecture made sense to you. It is absolutely from Nelson, and you can just listen to this lecture once and go through your textbooks. It will become easy and a cakewalk. You just have to breeze through topics and read once or twice before your exams. And I think you'll be able to write quite a few points and a lot of things on this topic. I hope it is asked on your exams. Thank you. See you again with some new topic. Have a nice day.